studies where hopefully I'll be able to pull a lot of the information that people have already presented today together. So if we look at the cases in question, I don't think there's ever any such thing as a perfect case. So what I'm going to do is try and present you rather boldly in 27 minutes, two slightly different cases to give you almost a different thought perspective as to how you might go about an injury mechanism within a hamstring situation. So this is the first case. This is, just watch this video and then I'll talk you through it. The guy you're interested in is the guy nearest to you, the one on the left you're looking at. So he's gone over the hurdle, and as he went over the hurdle, that left leg, which is his trail leg, has picked up a hamstring injury. It's actually just coming up to the Berlin 2009 World Championships in Athletics, and I can't spell Berlin, so put a G in there, but there you go. This guy on the closest to us is ranked world number 4, so he's in chance of getting a medal. It's 8 days prior towards his heats, so his first round within the World Champs. And this is a training session that he's doing, and he sustained a grade 2C under the BAMIC classification system, 5 centimeter tear into his biceps femoris long head at the proximal MT junction. Okay. So my question to you guys, just to think about over the next couple of slides, is the athlete then turns around to you, the coach says, look, we really want to race. We're 8 days out. Everything you've heard about tissue healing into tendons is it's going to be about 6 weeks, etc., before you've got that, if not months, if not years, before you've got effective remodeling. What would you do in 8 days in order to try and get this guy to compete and see what will happen? And would you take that risk based on all the risk analysis we've seen already from Nicole, etc.? And I think that's the reality of high performance sport, is we can have these beautiful models as Nicole presented, but sometimes we've got to take those models, adapt them, and think about how can we try and influence what's happening on the ground. The other case I want to present just now, just if you think about female 100-meter sprinter, just watch her coming out of the blocks, please. Okay, so very short, choppy stride. I'm going to hopefully pause that there. Huge injury risk or injury profile, from recurrent injuries year in, year out, from hamstrings to groin to Achilles to buttock pain. And adductor injuries, so a lot of soft tissue overload within the lower limb complex. Other physical qualities that you probably need to take into consideration are the fact that she's got a structural scoliosis, she's got bilateral femoral antitorsion, but she's got mobile hips of greater than 115 rotational axis, almost like a gird within the hip joint, and she's got a tibial varium with a mobile cavus foot, which will increase the relative demand on the hip complex in terms of the way in which the feet work. All right. So they're the two cases. Now, we presented this slide years ago, back in 2009, and it was Matt Lancaster, who's a great physio and mentor of mine, who's now down in Tasmania, and Paul Dijkstra, who's already been mentioned, who's over in Aspetar. And again, we came up with this comment that there's a dichotomy within hamstring injury risk and what people perceive. You'll never get injured if you're strong, you're well conditioned, you're balanced, you're in line, people are working on you, keeping you healthy, etc., and you've got this elite team behind you. Then there's always a chance of getting injury if you run fast enough, and that's just the nature of sport. So if you push that red line and you're trying to look at high performance sport, which is certainly the Olympic world, where it's very linear in terms of its outcomes and physical qualities, then you've always got an increased risk. And we can reduce that risk by not training so hard, but we're not going to win anything. So where do we sit? So that then leads me into this sort of next video footage, which I'll run with as we go. Now, the guy in the middle in the blue, as you're going to see him come forward, that's Tyson Gay, US Trials 2008. And in the quarterfinals, he's run 9.77, which is the US national record. So he's regarded as the fastest American of all time. He's faster than Carl Lewis, Leroy Burrell, Justin Gatlin, multiple Olympic medal winners, right? And then he went on a day later and ran the fastest US time in history, albeit wind assisted, so it didn't count as a world record. And again, so in order for him to do that, he had to have been in pretty good conditioning. That's at that moment in time, that was pre-Usain Bolt's Olympic world record. And that was, again, the fastest time ever in history, albeit wind assisted. So what happens off the back of that? So 2 days later, he's come out to run the US 200 meter trials after winning the 100 meters. And this is what happened. Now that's a grade 3C rupture, if not 4C rupture, depending on how you would have classified it. Back then, we didn't have the Bannock classification, so difficult to actually reevaluate of his proximal biceps femoris. So if we go back to that dichotomy, and it may even be a paradox, you will never get injured if you're strong, you're conditioned, you're balancing in line. Now this guy's got to be strong, conditioned, balanced in line. He's just run the fastest ever in history for any human being. However, if you push that red line, you've always got a risk. Now, the current evidence will say, well, if we can restore the architecture, then we're going to reduce that risk. But that may well be a paradox, because by improving or changing and influencing the architecture, we may allow for more force, we may allow for more capacity, therefore we may allow to run faster. And as Brian Heidset just showed, well, the faster we run, the exponential risk increases in terms of the work demand on the tissue. So there's a certain balance that's got to be achieved across all of this. So then that then leads me back into sort of some of the science. And there's some incomplete questions in this for me. The basis behind this is we've got to look at our diagnostic criteria. And at the moment, the diagnostic criteria is anatomically based. It's a structural-based classification system, which is a traditional medical model, and it's the right way to do things. It's a good framework to be on. We need to understand a bit more around the pathophysiology, and I think that's some of the things that we can possibly influence. And then we need a greater understanding of function and how different people use function, and where we might need to shift bandwidths or parameters within that function within different people and different population groups, different sports in which we're working with. And then that then influences your recovery and rehabilitation model. So I'm going to delve into the anatomy a little bit and just fly through this, but I don't think it's been covered as much other than possibly by Craig earlier. So the anatomy is complex. You've got the lateral hamstrings attaching on the inside, the medial hamstring attaching on the outside. They're overlapping, and as Craig spoke about, there's intermuscular communications, and that's been clearly shown by Askling as well. And there's this conjoined tendon between biceps femoris and semitendinosus at the proximal element. We've got difference in shape at the ischial tuberosity, where semimembranosus is crescent-shaped and biceps femoris is more oval-shaped, but with a much smaller aponeurotic attachment. And so again, maybe that influences its ability to produce force and absorb and transfer energy as a biarticular muscle. Semimembranosus, as I said, originates from the lateral, and semitendinosus biceps from the medial. But also there's a complex insertion. So semimembranosus has got 5 different attachments into the inside of the knee and will influence the oblique popliteal ligament, whereas biceps femoris will influence the arcuate ligament. And so knee mechanics, change of direction, become a key component within influencing what's happening in the hamstring. As we move anatomy into function, well, we naturally have this question around how many muscles and the role of the different muscles. We know that semimembranosus is the largest and biggest force producer. We know that semitendinosus is more about excursion and probably influences speed through large range of movement through its tendon, slack, and fiber length. And biceps femoris has that combination of high force and high velocity. We've then got short-headed biceps femoris that may well add to possible stiffness and pre-tension the long head to influence it more effectively. We've got that interrelationship around the knee into the superior head of the fibula, and we've got the insertion into the medial aspect of the knee. But then we've probably also got adductor magnus, which has been shown by the Takazawa research as well. And you look at the size of adductor magnus, then it's a huge muscle. And it's got fibers that go down and insert onto the medial aspect of the knee. It's got adductor magnus 1 at the top there, AM1. That's more of a hip stabilizer and rotator cuff, whereas AM2 and AM3 were probably more of a hip extensor in their influence, which Fionn spoke about in terms of the deep hip flexion loading that you saw earlier. And the slides down the bottom in the cross-section area is Jordan Mendicuccia's work, where looking again at adductor magnus proximally taking up a large percentage of the cross-sectional area of the thigh. And so if biceps femoris proximal MT junctures is the most common injury, you would think just looking at the anatomy, adductor magnus is critical. So maybe there are 5 muscles, and maybe adductor magnus is the 5th and a key muscle towards influencing what happens in the hamstring complex. So if we're moving on, and so again, just to highlight the anatomy here, this is an elite level sprinter who's run 10 flat. That's his short head of his biceps there in a visual, and the long head of biceps. There's his long head and short head again, and there's his lack of magnus and or semimembranosus. So if he's getting recurrent hamstring injuries, and particularly biceps femoris, which this kid was, well, is he getting it because there's a lack of eccentric strength and capacity in the muscle, or is he getting it because there's an inefficiency within the synergy and the other muscles in the way in which they're contributing and supporting it? That raises that question. Classification's been gone through already, and we've spoken about that. The one thing that I don't think that's been spoken about in enough detail possibly is just looking at the biochemistry here and looking at vascular endothelial growth factor and nitric oxygen, which Paul Head would have implied upon and spoke about within his blood flow restriction talk. And maybe these are key things that you can influence early within your rehab phase that can then influence getting that athlete back to racing in 8 days. And that's certainly a process we went down within our rehab model. Again, there's been talk around the differences in the classifications, and I think it's important to raise because it possibly means we're not comparing apples with apples across the ponds, shall we say. So you've got Petra's classification, which was used by Ekstrand. We've got the BAMIC classification, we've got the Barcelona, we've got the Munich classifications. What we do see is that certainly within the Champions League, there's a predominance or prevalence of grade 0 to grade 1, and possibly what I've seen in Australian literature, and certainly in Aussie rules, is that maybe there's a higher prevalence of grade 2 injuries. So again, if we're comparing Australian research and rehab and Australian impact factors to the, let's say, the European, we've got to again say, well, are we using the same classification? Are we comparing the same injury? Even though it's just stop classifying hamstring injuries as heterogeneous in their nature. So it's starting to differentiate that in a bit more detail. As we move into the functional hamstrings, it's largely been covered in terms of this high velocity movement. I think a couple of things that are worth noting in team sports as on top and or in sprinting is that it's this mouthful in the middle where it's an isometric paradoxical knee extensor, which goes back to what Brian was saying in terms of does it get injured on stance phase in Peter Bruckner's work and John Orchard's work, or is it in swing phase in that eccentric element? So we need to understand all of its functions. It shows a selective activation pattern during change of direction movement, and it stabilizes the knee in the coronal plane or frontal plane, as well as controlling tibial torsion and potentially influencing lumbopelvic function as well. So all of these things need to be taken into consideration and not just looking at the hamstring as an eccentric control of the shank in terminal swing phase and or just purely a biarticular muscle around the thigh. We've seen risk stance versus swing, so I'm not going to spend too much time on that, but certainly if this is available, you can look at that in a bit more detail. But again, the arguments over when we get injured and again, a bias towards the swing phase. One of the things I wanted to highlight here was the fact that when you look at a good quality sprinter, that's, let's say, a true track sprinter, they're not allowing their shank to go into full eccentric capacity. They're hip extending before the shank reaches that terminal swing phase, which means that the muscle is never truly elongating into that eccentric component. And in fact, actually you're negating some of that eccentric within the muscle, but you're probably increasing the eccentric load within the series elastic component or the non-contractile tissue. And that's possibly where the real benefit comes from doing the eccentric exercise. So the initiation of that hip extension moment, now whether that's glute max or adductor magnus, we would argue in swing phase that's adductor magnus. Certainly the evidence around biomechanics would imply that. And that glute max is much more important on the stance phase as you go through the glute med. So then that influences possibly how you think about loading a hamstring, particularly if you've got 8 days, or thinking about how do I reduce the risk of recurrence in a hamstring injury.